Topbed Talk.
So we're going to introduce our next speaker, Dr. Lee Fleisher, who is from the University of Pennsylvania, and he's going to be talking to us about the Brain Health Initiative, which came through the American Society of Anesthesiology. Thank you, Lee.
Great, and I'm also going to be talking about POQI, the POQI on delirium, as well as what we can do tomorrow, and that's one of the questions. Yesterday in TRIPOM, we talked about choosing wisely, and there's actually an initiative ongoing right now, and using the Choosing Wisely framework are what are the 5 things you can do to implement in your hospital tomorrow, and we're actually getting an international group to identify those 5 things, and we're hoping at the World Congress next year to actually integrate with other societies throughout the world. This is important, this idea, and you've seen this, the idea of how many older adults, and we now call it older adults in the United States, are actually undergoing at least one surgery. And because of that marked increase of the baby boomers and the ability to live longer, we heard this morning about the number of individuals who will undergo surgery in that last year of life from Evan. There's the idea of really the vulnerable brain. And from our perspective, the idea of the developing brain, which has not yet been the focus, that's the smart tots and a lot of the work that they've been doing. The postoperative delirium, which we frequently say is an acute brain failure, this fluctuating consciousness. And one of the key things when we talk about the data in this space is whether or not it's actually hyper or hypomanic delirium. That probably about 50 to 70% of the delirium would not go at all recognized. In fact, it's the ideal patient to send home because if you ask them, they're totally confused, but if you look at them, they're totally quiet. So to say we don't actually have delirium may not be as effective than if we did something like the CAM ICU or the 4AT or any of the other ways to assess delirium. And what's become much more popular now, Liz Everett and others wrote a paper published in 5 journals, is this idea of a nomenclature of postoperative neurocognitive disorders or brain fog. And I usually like to start with a quick story. There are actually 2 here. This is Irv. Irv sent me this letter, which, as the chair of anesthesia, you never like to get, in which he said, he experienced several instances of hallucinations. The nursing staff, of course, attributed it to anesthesia. What else would they attribute it to? And that something is amiss at my hospital. He actually talked in the letter about a friend of his who had sexual hallucinations while in the hospital. So there were 2 stories in one, and I'll let Irv describe it in his own words.
And suddenly, the room turned on a 45-degree angle. My bed was suspended from the wall. They were sitting down near the floor. The television was on the floor. I knew I was hallucinating.
You know, these are the patients that we worry about and that we clearly need to do better. And what was interesting is he went home. It happened again at home. It happened about 50 hours, and we asked him when he finally got good sleep. It was about hour 72. So it's something we need to think a lot about. We know delirium is quite common. It can occur from 13 to 50% of non-cardiac surgical cases. Delirium in total is attributed to a lot of healthcare resources. 164 billion, that's not just surgical delirium or post-surgical delirium. That older adults, and I'll come back to this concept, it occurs much more frequently. But Sharon Inouye, who's sort of the guru in this space, has said 30 to 40% is actually preventable. So that's actually been the priority of lots of societies recently. The focus of the ASA is not only on delirium, but that long-term cognitive disorders. What's interesting is if you actually look at the implications of delirium, and certainly we've had a lot of focus with ERAS on reducing complications, and that if you have complications alone, it increases length of stay. It increases 30-day readmission, but delirium alone also increases length of stay. It can double it. It can increase discharge to what they say is institutional discharge, so to a nursing home, and the combination of the two profoundly affects what happens to our patients postoperatively. This is just an article that I think has caused a lot of change in what's happening at our centers in the U.S. This ran through Kaiser Health News. So I frequently now have patients come in and say, am I going to be the same after surgery? Can you make sure that my brain health is protected? And I'll talk about what I think will happen over the next several years because of some work of what's called AARP, which in the U.S. is the Association of Retired People. Almost everyone over 50 gets a card because it's a discount card, and that, in effect, they have a newsletter that goes out to 30 million individuals, and that they are publicizing the issue of delirium as a high-priority item. And Rod Eckenhoff at my institution talked a lot about this, and that patients aren't able to do some of the same things they did before they went to the physician. When you ask patients and their families what they care about, they're very concerned about the issue of their brain health postoperatively. They're concerned about their independence, they're concerned about their mentation, and they're concerned about their money. Those are the three things that we hear, at least in the U.S., of that security.
I questioned the surgeon, and I said, well, I feel fine physically.
This is Kathy.
I feel like I have memory fog. And he said, yes, I've heard this from some of my patients, and it appears that it will clear in about 3 months. And I said, well, thank you. It was really nice to be validated. So, however, mine didn't really clear until about 4.5 months. I also had a procedure 6 months ago, not surgery, but I did undergo a procedure where there was anesthesia used. And that procedure was a heart catheterization. And I experienced the same thing, but it only lasted about a week and a half.
So the interesting thing about Kathy's story is a couple. She said she needed to be validated. So in fact, when she went back to her normal routines, she is a standardized patient. I don't know I assume you do those here too, for the medical students, in that she teaches medical students how to do exams. And she's also a bridge player. So when she went back, actually all the men, when she told the story, they actually discounted her internal feelings, and they poo-pooed her. Once the article came out in the Washington Post, they actually said, it happened to me too. So it was an interesting gender bias. The second thing is this idea of it can happen after any type of analgesic. It clearly is not an anesthetic that she got for her cath. But in fact, that Lars Eriksson has recently shown in a study in Scandinavia that it's just even the hospitalization that has this effect. So it may be that anesthetics play a very small part in what's happening to them, but it still contributes. The other thing that's going to be what we're concerned about is this story. And Sharon Inouye has done some fascinating work where she said, if you develop delirium and you follow these patients out for months, there is a different trajectory than if they didn't have delirium. Now, this is not case matched. We don't know, importantly, this is an association, that if you had prevented the delirium, whether or not you would not have gone on to have dementia. But the Alzheimer's Association has been looking for what can we do for these patients. And the question now is, if we have focused interventions that reduce delirium in the hospital, will that be one of the interventions that affects long-term trajectory into dementia? So that is probably going to be coming out as a focused question over the next 6 to 12 months. So we got together with this consumer health group, which we thought was critically important, and they have a global council on brain health. There's going to be a publicly facing report that will come out sometime in the next 6 months. The meeting is at the end of this month with people from throughout the world, and how do you address and how do you prepare yourself as you're coming in for surgery to reduce that risk of delirium. These are some of the things that came out of the ASSA call to action, basically improve communication, providing strategies, providing awareness. There should be a campaign and educating funders to actually fund a lot of this work. But I'll really go on to some of the things that we can do specifically tomorrow, as well as some of the issues with the POQI. So one is actually some form of cognitive screening. This is work from Deb Coley that was published with this nice infographic in which she showed that you can do a simple mini-cog, asking to draw a clock face, 10 of 2, asking a couple point recall, and if you have 3 or more points, then those are higher risk. Now, for anybody who knows Deb Coley and the Brigham, they say we are in Boston, so we actually, in West Virginia, or Kentucky, you may have to start at 65, but in Boston you start at 70 because they have a higher educated population. But that would come from an institution in Boston. But you can decide locally what you think should be the cutoff to start doing these type of tests. And in Philadelphia, we're going to actually start at 65 in asking individuals key questions to identify the high-risk subset. So these are the POQI recommendations, and we spend a lot of time. You may remember we use grade. So is it a strong or weak recommendation? And grade D means that we're not sure about the point estimate. We're not sure about the quality of the evidence, and it's sort of a lower grade. But we still recommend that hospitals and health systems develop processes to reduce the incidence and consequences of delirium. A little bit of mother and apple pie. I'll talk at the end about what people are doing in the U.S. around this. They recommend healthcare providers identify surgical patients at high risk. So essentially a recommendation for screening as patients come in. And lastly, they actually be informed of that risk. A little bit more concerned about what would they do if they're informed. But in fact, having family more aware, the caregivers, that in the hospital, helping them orient their family members, and at home, really assessing whether or not they've come back to baseline. Because certainly we know that patients will go home, they'll drive, they can get into accidents, they can get scammed, these older adults, if they're not back to normal. This again is the clock face, and this just shows one perioperative period that Deb Coley again did this very nice study showing that postoperatively patients lose their higher cognitive functions. Now, the question of what can we do in the operating room, there's been a lot of debate, and this was quite vociferous at the POQI meetings, about whether or not you do intraoperative brain function monitoring, intraoperative EEG. There's very nice work from the Mass General showing that if you that those patients who have a higher incidence of burst suppression, not a BIS number, but actual burst suppression, longer burst suppression, they have a higher incidence of delirium. The question is, if you actually intervene, will you see a difference? Or is it just those brains are more vulnerable to the effects of our anesthetics? And this was the ENGAGES trial, published by Michael Avedon, was the principal investigator, the new chair at WashU. And essentially, he had two interesting findings. One is that titrating to an EEG-guided anesthetic did not reduce the incidence of delirium, but actually there was a higher rate of mortality, which was a secondary finding. It was not the primary outcome. So that needs to be explored. There are additional trials ongoing that will probably be coming out over the next year or two, many of them from the Australia and New Zealand group. The other issue is really Beer's criteria, the idea of what drugs should or should not be given. And one of the key questions I would actually ask, raising hands, how many people think diphenhydramine is used postoperatively or perioperatively in your hospital? I can tell you the surgical house officers use it quite frequently. So we've tried to take this off the formulary. It was actually on a routine postoperative orders, and looking at these Beer's criteria drugs to eliminate, and we've focused on those agents like diphenhydramine that have the worst effects. So as far as intraoperative strategies, we recommend the use of multi-component non-pharmacologic interventions for the prevention of postoperative delirium. Minimization of medications known to be associated with the risk, and there are some data to say gabapentin is one of those agents. And there's insufficient evidence to recommend using process EEG monitoring. Now, we had 2 talks actually on pain today with slightly different perspectives. We've done some ethnographic discussions with patients, and at least in the U.S., we're starting to see patients avoiding narcotics because they're so afraid of becoming addicted. And then on postoperative day 2, when they're in severe pain, they finally take the narcotics again. So in older adults, I think it's really important that pain relief is the priority and that you try to avoid the side effects. But if you don't have good pain relief, these patients will become delirious. We also, as far as POQI 6, there's insufficient evidence to recommend any specific agents. Insufficient evidence to ask the issue of a regional neuraxial block. That's some work from Fritz Sieber, in which he showed that particularly when you do a block, most people have some sedation alongside this. And remember, it may be the hospitalization itself that's the major contributor to these issues. So he found no difference. There's the REGAIN trial that's also asking this question that hopefully will give more information. As I said, we recommend optimization of postoperative pain control. That's the highest priority. You may be opiate sparing, but again, if they're in a lot of pain, that will increase the incidence of delirium. And essentially, there's been a lot of trials asking prophylactic, ketamine, clonidine, other agents, and we did not find any evidence that anything particular works. This was an interesting perspective written by a nurse, as you see, about a parent and the Beer's criteria. And what was interesting is how many family members without a medical background are caring for their elderly loved ones and are unaware of the problem. They don't know about the Beer's list, which is actually from the American Geriatric Society, and they really rely on us to try to prevent giving the wrong medications. The key thing that really helps the most is something called the HELP program, the Hospital Elder Life Program, and it's really the idea of returning sensory aids, whiteboards with information, clocks, bedside presence of the family. If they have TVs in the room, putting on programs that they know are actually at a certain time of day that might help orient them. In my home, it's House Hunters International at 10:30 at night. So doing something like that would help orient our patients. This is a new initiative that's coming out of what's called the Hartford Foundation, which focuses on healthcare for older adults, the Institute for Healthcare Improvement, and the Joint Commission in the United States, our accrediting body. And it's the idea that our hospitals need to be age-friendly. We've had this debate a little yesterday, and it's the idea that we need to keep them mobile, mentating, worry about their medications, and find out what matters to them. And the interesting question, in the U.S., we worry a lot about falls. It's a measure. So, in effect, we don't mobilize them, but that's the best thing to decrease delirium. So I'll end very quickly. This is just some additional strong recommendations that they have a process in place. This is the new infographic. Hopefully it'll be published soon putting this all together, and I'll leave this up on the board as the last slide while I move to the questions.
Thank you very much. Great presentation. We've heard a lot about brain health. Actually, on Top Med Talk, we've sat down and talked a lot about it. We can find numerous conversations. Absolutely. Yeah, it's very important. It sounds like you guys are doing a lot of collaboration with the Brain Health Initiative and looking at groups. What are some of the other multidisciplinary groups that you guys are working with or trying to bring in?
Well, the American College of Surgeons is already doing this. We're hoping worldwide, as Mike said, we'd love other colleges throughout the world. But I think the key thing is that we have to engage the caregivers. Mm-hmm. So we have to go out to the consumer groups to actually say that there's an educational channel out to them, which I think is as important as what we do as healthcare providers. And, the other issue, I don't know in the hospitals in the UK, but there's a misconception that if you fall, you have to measure it and report it to the hospital and it has a negative consequence. Falls with injury is something we should worry about, but walking people, even if they fall to a knee for a short time, is the best thing you can do.
Is there any curriculum that's being developed for our trainees, our junior doctors and nurses?
It's a good question. I know the ASSA is, Committee on Geriatrics, is developing at least a series of interviews. Michael Avedon was one of the first for podcasts, but something we have to do next. Yeah. They're supposed to work on it.
So we're going to quick fire questions because we've only got about 5 minutes. What's the evidence that dexamethasone 4 milligrams IV for POM-B prophylaxis increases the risk of delirium or POCD?
We looked at all those trials, and that's why the evidence was nothing prophylactically had made a difference in the trials.
So we know things that exacerbate, but we don't know anything that protects. Is there prehab for the brain?
That's one of the interesting questions. If you look, the Global Council on Brain Health yesterday said they came out with new guidelines. Certainly none of the supplements seem to work. There are experiments about whether luminosity or any of those brain rehabs, but believe it or not, we actually do believe that classic prehab that you've been discussing for the last 2 days is probably the best thing you can do for the brain. It's actually exercise, walking, all the activities you would do for functional status. Protects the brain.
Are there any scoring systems addressing risk of never returning to independent living?
Not that I'm aware of. Are you?
Not that I'm aware of.
Yeah.
Great question, though. Yeah. Do you think excessive opioid use in the elderly contributes to postoperative delirium in the susceptible?
It's a difficult question. I do similar things to what Evan said. I tell patients, actually to what Bo said, I set them up for expectations, opiate sparing. But I think that our desire to have patients less aware, less awake, may be something that we need to avoid and really looking for the right balance. But I certainly think that too little opioids is bad. It's the Goldilocks phenomenon.
So emerging evidence from the ICU and medical ward settings that melatonin can assist in prevention and treatment of delirium, any in the peri-op setting. Did you consider that in POQI?
I don't think we saw any. Tim, we didn't see any trials on that.
Well, a great question.
Yes.
You mentioned steroids as a drug to avoid in the postoperative period. How about introspective dexamethasone?
Intraoperative.
Intraoperative.
Oh,
yeah.
Introspective is a great idea.
Think about it.
The evidence was, I think Michael Avedon did some studies on this too, that there's no difference.
Have we seen the very high-dose steroid studies yet, which I think Professor Henrik Kellett's been working on?
Right.
Methodologically, if we think the unifying theory is inflammation, you'd think that steroids might do something, but you're then playing effects off side effects.
Yeah, that it's a fascinating. Most of people do think this is neuroinflammation, so I don't know the answer to that. Henrik says he has no delirium in his patients because they're up and out. So either it's unique to his setting or he doesn't measure it the same way the rest of the world does.
I think you've dealt a little bit with the identify and treat. Do you have geriatric specialists involved in perioperative care?
So that's an interesting question that essentially, because of this, we put together a geriatric service and trying to really focus getting our hospital to fund a multidisciplinary group to focus on the 4 M's. So I think it's going to be a unifying force now around, but there's not enough geriatricians to see everyone. So it's really what people have talked a lot. We have, I don't know if you have it here, ACE units, which are acute care for the elderly, in which geriatricians run the unit. It really started as a hip fracture service unit in many places, and it sort of spread from there. And the idea is if you have a few units in which best practices are adopted, then it can be adapted throughout the whole hospital. The group that I heard that people are most worried about in the U.S. are hospitalists, because they're not trained as anesthesiologists or geriatrician, and they're not trained in postoperative care, so they're very concerned.
Right, I'm really sorry you have to truncate, but say a big round of applause. Thank you.
Great job. Thank you so much.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Peri-Operative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.